On behalf of the Northwest Mental Health Technology Transfer Center, I'd like to welcome everyone to today's webinar. I'm Dr. Lydia Chwastiak. I'm a psychiatrist and professor in the Department of Psychiatry at the University of Washington and a co-director of the Northwest MHTTC. And we're really excited to sponsor this 60-minute webinar from Dr. Irwin today on the topic of advancing equity in cancer care for people with mental illness. And in the US today, a person living with serious mental illness has on average a life expectancy that's 25 years shorter than that of the general population. And the vast majority of this premature mortality is due to medical illness. So this webinar is going to highlight some of the health disparities that people with serious mental illness experience in cancer care that contribute to increased cancer mortality. And we'll also review some promising approaches to care that can target some of these health disparities. So it's a 60-minute webinar. Wanted to just highlight a few housekeeping items. We will have 10 minutes at the end to do a question and answers with Dr. Irwin. And so we're asking people in their, enter their questions. They have questions throughout the talk to enter them into the Q&A box. And then we'll compile them and review them at the end of the presentation with Dr. Irwin. But if you have technical issues, please submit your questions in the chat box, and one of our staff will work with you to troubleshoot. The webinar is sponsored by the Northwest MHTTC. And so we're part of a national network that's funded by SAMHSA. And our goal is to increase the implementation of evidence-based practices for people with serious mental illness. And so this slide just shows an example of our network. We're up here in the Northwest in HHS Region 10, and the whole network is comprised of 10 regional centers and a coordinating center that's at Stanford, and then national centers that focus on Native American and Native Alaskan populations, and also a center that focuses on national Hispanic and Latino populations. And so together our collaborative network supports resource development, dissemination, training and technical assistance, and workforce development for the mental health workforce throughout the United States. It's a big network. The Northwest MHTTC is based, as I said, in the University of Washington in our Department of Psychiatry, and we provide training and technical assistance and evidence-based practices for the behavioral health workforce in Region 10. And broadly, our goals are to heighten awareness, knowledge, and skills of the workforce in addressing the needs of individuals with mental illness, and to accelerate the adoption and implementation of mental health-related evidence-based practices, and also to foster alliances among culturally diverse mental health providers, policymakers, and family members and clients. And one of the areas that we're focusing on in our MHTTC is integrated care. And today's webinar is the first of a series of webinars by national experts on the topic of improving the medical care and medical outcomes of people with serious mental illness. This slide is just a reminder that it's our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. And we encourage all clinicians to use and to champion person-first language, which emphasizes the individual, not the condition or the disability. Person-first language is a way to demonstrate respect for person's dignity and worth, and it's consistent with recovery-oriented practices and promotes treatment environments that foster respect, human dignity, and hope. It's my great pleasure to introduce our speaker at our webinar series, Dr. Kelly Irwin. Dr. Irwin is an assistant professor in the Department of Psychiatry at Harvard Medical School. She is a faculty psychiatrist at Massachusetts General Hospital Cancer Center and also the MGH Schizophrenia program. And she's the director of the Collaborative Care and Community Engagement Program, which is a research and clinical program focused on improving cancer outcomes for people with severe mental illness. She's a lot of collaboration with community partners and the Massachusetts Department of Mental Health. She has been at Harvard a long time, getting both her undergraduate degree and her MD and an MPH from Harvard, and doing her residency at Mass General and McLean Hospital, residency in psychiatry. And currently she's leading a randomized trial funded by the National Cancer Institute, investigating the impact of proactive psychiatry consultation and case management on cancer care for people with serious mental illness. So I'm going to turn it over to Kelly. And as I said, please put your questions in the Q&A box. We'll leave 10 minutes at the end. We'll also leave 5 minutes at the end for a brief evaluation, which is required by our sponsors. So wanted to just give everyone a heads up that, to ask you to complete the evaluation at the end. Great. Okay, Dr. Irwin.
Thank you so much, Lydia. It's really such a privilege to be here with you and to talk with all of you out there. We certainly share the mission to really advance evidence-based practice for people with serious mental illness, and also to make sure that we're using person-first language to do it, and to think about these integrated care issues as really the human right to health. So if you Google Cancer Center and you Google mental health clinic, these are the images that come up. For me, as a person and as a clinician and researcher, when I look at these images, I'm struck by how differently we invest in cancer with shiny glass buildings versus strip malls for community mental health, and also how fragmented our care delivery system is. That these systems don't share a medical record, that clinicians rarely walk in both those buildings, and that often the burden is on the person affected or their caregiver at a time which is really vulnerable. And that really sets up a situation which is really going to make it very hard to get equitable care. When our system is fragmented, this is the kind of disparity that can result. As Dr. Schwastiak said, people with serious mental illness are dying nearly 30 years younger than the general population. 80% of that mortality gap is from medical illness. The number one cause of death is cardiovascular disease, and the number two cause of death is cancer. Cancer is a really encouraging story, one of the most hopeful stories of our healthcare system. If we look in 1975, only 75% of women were surviving when they were diagnosed with breast cancer, and now we're above 90%. However, we know that not all populations are benefiting equally from those innovations in care. And people with serious mental illness, in particular schizophrenia, are some of the most marginalized who experience a double disparity given high rates of poverty compounded by the challenges of mental illness. And that leads to a situation where people are 2 to 4 times more likely to die from breast cancer because they're less likely to access these advances in cancer treatment. And we see that pattern repeated over and over again, that people with schizophrenia are 2 to 4 times more likely to die from oral cancers, from colorectal cancer, from lung cancer. So it's not that people are any more likely to be diagnosed with cancer, it's just that they're more likely to die from it. So what's going on? If we try to break this down and think about ways in which we might intervene as mental health clinicians or as our behavioral health workforce, we can recognize that there are a number of factors that are impacting the continuum of cancer care and leading to increased suffering and poor survival. And what we have found is that there are inequities throughout this continuum of cancer care, so that people with serious mental illness are less likely to be prescribed guideline concordant smoking cessation treatment. They're less likely to get mammograms. They're less likely to be diagnosed on time with their cancer. And even when they come into a nationally accredited cancer center, they're less likely to get recommended surgery or chemotherapy or immunotherapy. As I heard just before I came into this webinar, one of our referrals was told, well, you can't get radiation because you smoke. And we know that that's not actually consistent. And I can't help but wonder if that might also have to do with their comorbid schizophrenia. We also know that people with serious mental illness are less likely to be referred to palliative care at the end of life. And also that people are more likely to come into the emergency room and be in the hospital and die in nursing homes at the end of life. So what might we be doing about that? How could we help intervene on this? I think that one of the most encouraging things that we've learned as we've looked at this systematically is that there are modifiable factors that we can target, and that if we think about these inequities in care that contribute to increased cancer mortality, what we find is that people who have a psychiatrist, people who have been prescribed antipsychotic medications, at least in a population of women with schizophrenia, those are the factors that are most strongly associated with getting the breast cancer treatment that they need. And that's something I think we can do something about as a behavioral health workforce. So that's really encouraging. So if we're going to break this down, these quotes come actually from qualitative interviews with oncologists and mental health clinicians. We think about what patient factors might be impacting a person with mental illness's ability to get cancer care. What might happen if they had uncontrolled psychiatric symptoms? Maybe they might not be able to establish trust. Maybe they wouldn't have recognition of the risks of not getting treatment. And what might happen if the person came and saw their oncologist and it seemed that they didn't trust them, they weren't sure if they were understanding what they were saying, then the oncologist might worry about doing harm and might be less likely to recommend a treatment. Because I think as clinicians, as physicians, we worry about that, understandably. We don't want to do harm. It's also really important to note that people with serious mental illness experience social isolation. They're less likely to be married, have higher rates of poverty, may have challenges accessing stable housing or transportation to get to the hospital. As this nurse states, if they don't go home to a roommate or a family, they don't have anybody there. How might I feel about giving them chemotherapy and wondering about whether or not they'd be safely able to monitor those symptoms? I think we're all increasingly learning that the caregivers for people with serious mental illness are much less likely to be spouses. They may be children, they may be parents, they may be frontline community mental health staff. And we realize there's a lot of research to be done about how to best support those caregivers as well. We think about clinician level factors. I mean, this quote resonates with me from what I hear from oncologists. It's very easy for an oncologist to feel overwhelmed. We're not trained to talk about cancer with schizophrenia front and center. We lack education about tailored communication strategies. And we lack education across disciplines. Similarly, many mental health clinicians get very overwhelmed when thinking about cancer or end of life or multimodality treatment. So we really need interdisciplinary team-based approaches to education to break down this barrier. And finally, we know well that mental health care and cancer care are delivered in separate systems that often have barriers to communication, some imposed by HIPAA, some by not sharing an EHR, some by assumptions about whether or not mental health clinicians and medical clinicians are talking. And then finally, just that there is just a lack of access, just inadequate care. It doesn't make sense for someone who is diagnosed with a life-threatening cancer to be referred to a mental health clinic, have to make 2 appointments with a therapist and wait 2 months before they see a psychiatrist. That just doesn't work. Because with cancer, we can't wait. And what might be ways in which we might help all of us to understand the value of collaborating? And I think that discrimination is at the middle of that circle because discrimination really plays out on all of these levels. At our own assumptions as clinicians and also as people with experience and caregivers about what care we might anticipate and in the way that the healthcare system is actually designed. The final human rights issue that I wanted just to briefly mention is that individuals with mental illness are excluded from 1/2 of clinical trials, whether those be cancer clinical trials or collaborative care trials. And these trials can actually be potentially life-saving. So this is another human rights issue. And I think it's true, it's savvy of this oncologist to note that there are people who falsely assume that patients can't give informed consent or won't understand, and people kind of write off this population. So what might we do about that? How could we approach things differently? So this is the key message that we were talking about before. If we present all these kind of more grim statistics, what can we be hopeful about? I think we can note that if we're able to identify this population proactively and link them to mental health treatment, we have a good signal. That might be an encouraging strategy to link people to the care that they need. So this is Joan and Jonathan, who I met about 4 years ago. Joan had cared for Jonathan for many years as mom, and he was 42 when I met him when he was diagnosed with colorectal cancer. He had coped with bipolar disorder for many years in his life. As his colorectal cancer got more severe, his symptoms of his bipolar disorder also worsened. He grew depressed, more irritable, highly paranoid, and agitated. He was in and out of the hospital, both medically and psychiatrically. And as he grew more paranoid, he certainly did not wish to come to see another outpatient appointment with a psychiatrist. So he had declined consultation a number of times. And yet here we were with a person whose mental illness was worsening. And now what was happening was there was concern that he wasn't getting the cancer care that he needed. what might we do about that? What kind of an approach might we have to do things differently? And I think, most fundamentally, what might we do to kind of meet him where he was? I show this other picture to illustrate another patient who I think if you're working in the community mental health environment, if you've worked in a group home, you've worked with people who are not connected to their families. This is a person who always was dressed very stylishly in black leather jackets. That's why that's up there. And who after 20 years of being, lacking stable housing and experiencing significant trauma, had been able to really make a home for herself in her group living environment and establish some trust. She had smoked 1 pack a day for 20 years. She began to cough and lose weight. She had been hesitant to go to see her primary care doctor, but her mental health nurse practitioner encouraged her to go. She went to the clinic, had an x-ray, showed a new lung mass. Unfortunately, she became very upset, literally ran 3 miles across town and crouched on the steps of her group home and refused to seek other care and said, I don't think I have cancer. I think you guys did this to me. This is all the healthcare system, and just progressively got sicker. And the question would be, what would we do as a behavioral health workforce, or for me as a psychiatrist, how could I help in that situation? So, yes, I think sometimes all of us feel helpless. And when we feel helpless, I think that's when we start to make assumptions about what people can and can't do. And I think we sometimes lose our access to our creativity. And it really takes, I think, a team to support people with kind of getting out of that kind of train of thinking. And for me, the more I feel helpless, what I've realized is the more important it is to think about that individual's strengths and what matters to them, and have that be a strategy to frame their cancer treatment. And that is really a really core principle that we apply to our model and to our research studies and to our approach to advocacy that we'll talk more about, that really resonated with Jonathan and with our second person who we'll call Sally, and that we'll get back to as we go through the strategy. Because I think this is true, like for all of us, what might change if we met people where they are. So if we didn't insist that they come to see an outpatient clinician in a separate office, if we didn't stop when someone declined care, or stop when someone said they didn't believe they had cancer, but instead maybe went to them, not just physically, but maybe sometimes physically, but also in terms of understanding what mattered most to them, whether it was being with their family or being able to stay in their group home. And I've really been struck by how profoundly and significantly the decision-making can change when we start to ask the question differently. I think that there are understandable concerns that we don't want to ever forget about people's autonomy. But without understanding and full information about the risks and benefits, it's very challenging to have that autonomy. So I think we really need to be mindful of those questions and how we can build people's understanding. So this is really the person-centered lens that we've applied to our research program and to our clinical model. And we're going to talk more about the model of care delivery and how we apply it. This is also the model that we're investigating in the current randomized trial. So currently in the cancer center, let's imagine what might happen. Someone with schizophrenia comes into an office with an oncologist. It's just that person or patient, they might say, in the room with the oncologist. Might not have their full medical history. The person might feel overwhelmed, as anyone might at the time of cancer diagnosis. And I don't think that interaction has always led to the most person-centered or effective planning for cancer treatment. So what if instead we did something different? What if we proactively identified all people who are affected by serious mental illness at the time of cancer diagnosis? What if we thought about who's this person and who's their caregiver? Maybe it is their mom in the case of Jonathan, maybe it's their program manager in the case of Sally. And what if we proactively engaged a collaborative care team, specifically a psychiatrist and a case manager, and so that the oncologist and the psychiatrist could together, understanding the person and the caregiver's values and needs, shape a treatment plan that integrated their mental health and cancer care needs. And that then by linking to a case manager or sometimes to a navigator, we could also address resource-related barriers to care and therefore prevent disruptions in cancer care and get them through their treatment. So maybe by using this person-centered team, this proactive approach, which is based on the evidence-based collaborative care model, maybe we would be more likely to get people through their cancer treatment, and therefore they would have better cancer outcomes. If we systematically tracked how they did, if we had a fairly proactive approach here, understanding that these are two high acuity illnesses with a relatively higher need for specialty medical expertise where we don't want to wait. And that we do have good data about what evidence-based treatments are for cancer and for mental illness, and that we could probably do a better job of increasing access to these interventions for people with complex needs. So that's the model that we sought to investigate. So this is Adi, who's given presentations at our seminars. When I met her, she was in the post-op recovery room and had not been able to get her breast cancer surgery because she didn't have a ride home. She was frustrated, understandably agitated, as were the nurses in the unit. So let's say here's her oncologist who is planning to have her surgery. I think they just hadn't thought necessarily about like who would be the person who would bring her home. Turns out that also she was pretty disorganized and had an untreated bipolar disorder that had been poorly managed, that she also had cognitive deficits that were impacting her memory, that she didn't remember which medications she was taking or not. So there was some work to do to bring in, let's say, a psychiatrist and a social worker to collaborate with the person and their oncologist to design a different care plan, to perhaps getting a visiting nurse in place to revise the medications, to make sure we're building understanding. Maybe even a navigator who could go out to the home and help work with the patient around other barriers to care and help support them by doing home visits. And maybe with this person-centered team, we'd be more likely to have success and actually be able to not just complete cancer treatment, but also improve functioning, well-being, and a sense of being cared for in the healthcare system, which is critically, I think, important. So that was what we studied in our first trial. This was really a feasibility study. We were curious, could we enroll in a trial people with really complex needs who had schizophrenia and bipolar disorder, severe major depression, and a new cancer, who could have comorbid addiction, who frequently were also homeless, in a real world setting? Would it be possible to participate in a clinical trial? And many people had concerns that it might not be. So we also felt that to really understand this, we would need to approach our process differently. And these same processes extend to our clinical model. So if we're thinking about how to build understanding, and we're thinking about how to do that, maybe it's really important to be able to have multiple structured conversations with a clinician to break information down into small pieces and use concrete examples, while also bringing in, a trusted person from the community to help build understanding over time. And so that was our approach to consent, rather than looking at a long written form, which might include a lot of legal language and lead to a lot of paranoid thinking. Additionally, it's hard enough to have bipolar disorder, schizophrenia, and a new diagnosis of cancer. We certainly don't want to add burden by adding additional appointments in different places. What if instead we could actually make sure we meet people where they are and actually help to integrate the care that they're also receiving? And even do joint visits, linking psychiatry and oncology, and hopefully use those visits as a way to kind of demonstrate tailored communication strategies and build understanding and do some education for the team bidirectionally. So that was our approach. What we found is that it was possible to identify this population, that we were able to accrue to our trial more than 3 times faster than our goal, that 90% of the people we approached consented, and that 100% had their assessment. And importantly, that 6 people who were referred to us who hadn't gotten the care that they needed, all of them got more care than they would have gotten through participating in our trial, and 5 got everything that they needed. Equally important, no one felt that they were coerced. And so this is feedback from patients and caregivers and oncologists, that it took a whole village of not just doctors, but clinicians and people, to support the person through this time of acute needs. And that caregivers, whether they be family caregivers or community mental health caregivers, recognized how unique it was to have someone who understood oncology and schizophrenia, that they never had a provider with both perspectives. And oncologists also valued the proactive approach and the ongoing availability and flexibility of psychiatry. Being involved throughout treatment was invaluable. As an oncologist, it made me feel more confident that we could accomplish something. and that this person would not have gotten cancer care without this intervention. So this is what 80 said. I didn't feel wanted. I kept getting pushed around. I had a lump for 6 months and I could feel them dismissing me. The team listened to me, and that was the difference between life and death. So this is our follow-up randomized trial, and we're currently enrolling people with schizophrenia and bipolar disorder and major depression, and hoping to learn about whether this model impacts our ability to give people cancer care. And downstream, maybe that this would be also associated with cancer outcomes, including mortality. Stay tuned. So more broadly, I think we need to think about bridges, right? We need to think about person-centered team care across settings. We need to use common sense. We don't ask people who can't walk to walk upstairs, but we seem to be okay with asking people who can't, have a hard time with organization and arriving at a consistent time to show up on a Tuesday at 8:30 in this specific location. Maybe we could do that differently. Maybe we don't need appointments before mammograms. Maybe we should think about where people are accessing care and embed cancer screening in those places. So for example, we're doing a pilot study of lung cancer screening, which is embedded in our clozapine clinic for people with schizophrenia, which was an interesting idea to pilot given they're coming to the clozapine clinic at least every 4 weeks. And amongst these 200 people, they saw 92 different primary care clinicians. And how we combine technology with peer engagement and really thoughtful involvement of the community to leverage technology to increase our reach, to do second opinion consultations, to leverage models like Project Echo in combination with maybe sending a navigator or a peer out to the community so that we're not missing the people who may be most vulnerable and in most need of interventions like this. So if we go back to Sally, the woman in the leather jacket, these are the words that were shared by her psychiatric nurse practitioner and by Sally after she participated in our trial, and then more recently after she died after 4 years of really great quality of life on immunotherapy. As her nurse practitioner said, our patients' lives matter. Even when they don't have families, they matter. And this person and patient who initially declined treatment expected to be dead. She was amazed that she could receive care and it would help. What Sally said, they made me feel like I mattered, like I had a choice. So I actually sectioned her as a Massachusetts term. I said she had to come to the emergency room for an emergency evaluation. Once she came to the emergency room, I met her in the emergency room with the medical oncologist, and we listened, and she told us how important it was for her to stay in her group home. And with that framework and talking about what could help her to be more independent, she actually agreed to participate in our trial and to receive radiation and then chemotherapy. And she did very well in immunotherapy for 3 to 4 years. And I think this is right, that we might be our patients' families. We are often the people advocating for our patients, and that being cared about is essential. This is what the nurse practitioner said as we kind of navigated another challenging aspect of care delivery for people with serious mental illness and cancer, the fact that we lack places for people to die when they're too sick to be in their group home. Where do they go? How do we help people transition to hospice? And so her nurse practitioner said, well, I'm overwhelmingly saddened about her death. I'm so glad she passed away on her terms, making informed decisions about her health and how she wants her body to be treated in her passing. She remained in her residence until a few days before she died, which was of utmost importance to her. Meeting her on her terms from the beginning is what gave her those 5 years. And when I went to her group home, joined by our navigator, we actually brought her oxygen. We had to change the formulation of it. That couldn't be an oxygen tank, it had to be an oxygen concentrator. And so literally she couldn't breathe, and we were giving her oxygen. And she said, thank you, I never thought anyone would do this for me. Give her air. So I think with that motivation, I think that along with probably many people on the call, we recognize that this isn't just about one hospital doing clinical care or one research trial. It's really about a coalition of diverse people coming together to promote equity in cancer care and research. And we certainly invite all of you to join us in that work. That really our mission is to ensure that mental illness is never a barrier to care. And we recognize that we need all of us to advance that mission. We're very grateful to our community stakeholder board and to our partners, and both our academic partners at Mass General and Dana-Farber and our government partners, the Department of Mental Health and our community partners, and to NAMI. And I'm very grateful also to Lydia for her mentorship and for the invitation to speak with you. We do have a symposium every year, and certainly it's free, and everybody is welcome to attend and just be part of our larger coalition. So I encourage you to check it out if you're interested. Thank you very much for your time.
Great, thank you, Dr. Irwin. That was a fabulous presentation, just really fantastic work. I wanted to just check in with our staff. We've compiled the list of questions that participants have put in the Q&A box, and so wanted to just kind of turn to them now and see what questions there are, and people should feel free to add them to the Q&A box right now. So we'll give people a couple of minutes to add their questions. I have a couple of questions. I think most of the people like me on the phone are involved in clinical work with the population and just really seeking some guidance. I mean, you're doing such extraordinary work with your multidisciplinary team, but just kind of thinking about guidance for individual clinicians, and if you have specific recommendations about how we might interact more effectively with oncologists or advocate better. I mean, do you have pearls of wisdom for us?
If you want to just, maybe if I can't control the slides, but if we just go back to my 10 pearls, yeah. I think those are helpful. I think the most important thing in terms of working with oncologists is to remember that you have to sit at the table. You have to present yourself as equally important in the person's care. No one is doing a favor to you by listening to your expertise about what someone needs. And so I don't say, hi, might you have a minute to speak to me? I'm really so grateful for your time. I say, this is Dr. Irwin from Mass General, and this is important that we speak about this. I'm concerned that you're not understanding. And here's what I want to make sure we can work on together. Not to say that, to mix that more directive style with being helpful. Mm-hmm. And really centering each other on the common goal, which is really to help the person that's in front of you. And that, I think it's really understandable that people feel overwhelmed, that the population may take more time, that we don't have enough access to psychiatry or the resources that we might always want to have. And so that it takes a team, and how might we flexibly be able to do that together. But I think once you're able to get somebody on the phone or in person, even better, mm-hmm. I find, often the conversation changes.
Yeah, it's about relationships with providers and really feeling like you're sharing care, which I think many, I'm curious about people who are participants who are on the phone about how much experience they've had with specialists, like for advanced cancer care, but certainly with primary care, just kind of thinking about that experience of how the relationship goes a long way. I think Sarah's trying to get your pearls your pearls up to share with everybody, so I advanced the slides too far. Great, thanks, Sarah.
Yeah, they're a little farther on. I mean, so I think in terms of the big picture pearls, I think we talked about the most important one in the talk, which is to understand the why. What's this person care about? Mm-hmm. What would be their motivation for cancer treatment? And the more hopeless you feel, the more you need to ask about strengths. It actually enables your mind to open up to more curiosity and creativity, and you're able to kind of think about things in a different kind of way, which is really powerful. And I wasn't always someone who got that. I was trained very medically, diagnostic model, and here, make sure I don't miss some sort of medical complication. That's not really the heart of this work. The heart of this work is understanding what matters to people and being able to think through with them why this choice might make sense. People often ask me about what to do if someone initially declines cancer care or they decline cancer screening, which I think is a really important question, because I do think that people, my experience is that sometimes people are very worried about not respecting people's autonomy. And that's, of course, important, but I do think it's really important to make sure people understand the risks and benefits of their decision that they're making, and often they don't. Because anybody who gets diagnosed with cancer is incredibly overwhelming. It's really hard to understand, let alone understand the different kinds of treatments that might be available, the different kinds of side effects, all the options. One of the saddest things that I hear from other mental health clinicians is that they thought the person was getting adequate care. You know, they'll say to me, I thought that was good care. And how would you ever know? Because cancer care is so rapidly evolving. That's why I shared that small anecdote from this morning. And I would say I probably get these, you know, a couple a week now. Just that it's actually, you can do radiation when someone smokes. There are at least 3 or 4 types of immunotherapy we might be able to use that people might take as an oral medication. There are always options. It is always recommended to get a second opinion. If you have a life-threatening illness like cancer, let alone you also have a comorbid condition, there are pearls. So I think that I've actually increasingly more strongly recommended that people come to a center or have a consultation with us where we can leverage that joint expertise, much like I would have no hesitation saying, oh, you have stage 4 gastric cancer. I know there's a clinical trial at this cancer center. I would never say, well, don't go. Of course I would say go. And similarly, I feel that the population we serve equally, if not more so, deserves that thoughtful second opinion to inform what approach might make sense, to make sure that we've considered all of the options. So yeah, these are my pearls. So start with finding common ground as a human. So that might be something as simple as bringing coffee the first time you meet with someone or the first 4 times. Think about who your ally is going to be. You know, is it the landlord? Is it the pastor? Is it the rehab manager? Who is it in the group home who they have the best relationship with? Who can bring them? Why aren't we texting people? Well, I do. It works a lot faster. I have like every visiting nurse in Massachusetts in my phone. It's just so much more efficient. And why aren't we thinking about that as a way to decrease the burden of communication? You know, and if you don't know something, if you're not sure what guideline concordant cancer treatment is, if you don't know what pembrolizumab is, it's on us to ask in an informed way, much like I would hope that the oncologist would say, you know what, I actually don't know what the side effects of clozapine are. Could you help me understand if we can give that with chemotherapy? Question HIPAA. Remember, HIPAA was designed actually to promote communication. It's the most misunderstood set of laws that I have encountered. If you are caring for someone on their care team, our goal is to be able to communicate. And so we really need to be thoughtful about that and get consultation before assuming that you can't talk to someone when you're worried. Why not do a home visit? You know, it's often more time efficient. You can totally bill for it. It's a lot less time actually to just take an Uber to a local community than call someone 80 times. In terms of, I don't know how many prescribers are in the room, but in terms of like when I'm thinking about prescribing, I think it's important to choose medications that have fewer interactions when we're expecting to give people chemotherapy. And we want to think about leveraging like the side effects of medicines to help, like things like, you know, poor appetite or nausea. And I think another thing is like, what if someone declines psychiatry? So what? I mean, that's the whole point of a collaborative care model. Well, is there a need? We don't say like, hey, are you really like, would you love to see a nephrologist? Would you really like to, are you interested in seeing cardiology? That's not what we say. We say, you need to see cardiology because you have severe heart failure. And so if somebody isn't open to seeing psychiatry, then I say, how can I help you support this person? How might we think about how you're going to prescribe these medications? And we'll call them for nausea because they have nausea too, but we're not going to stop the conversation. So I think that's a really important thing. And I think the other thing that, like, this is what my residency director always said to me, and I was sort of an odd voice, but it was like helpful feedback. Never worry alone. That's what she would say. It's true. So I mean, I think that like that's the whole point of like a technical assistance center like this, and certainly we as our coalition are an available resource. And I would encourage you, if you have clinical cases, to reach out to us. We really genuinely want to know and want to help try to problem solve with you.
Yeah, no, that's a very generous offer because I think that it's great advice. And I appreciate you highlighting the HIPAA issue, especially, I know we have some participants on from outside of Washington State, but at Washington State, we're going through Medicaid transformation right now, our 1115 waiver, and thinking about ways to integrate care. And it really is about being able to communicate and seeking ways to share information as opposed to looking for ways to looking at the restrictions. I think the other issue that I've realized clinically or learned from your work clinically is that it's not, these decisions are typically not one point in time, they're a process. And so that there tends to be a lot of drama and stress and worry by clinicians around a decision made at one point in time, when there is time to sort of get more information and develop more, figure out who someone's natural supports are, or put the team together. And so, sometimes it's an emergency or an urgent situation, but more typically thinking about it as a process. Although, in some of your cases, I assume the timeline is somewhat accelerated. It's important to realize that there's time to work together and to work and understand what the person wants and support that.
Yeah, and ideally give them the best possible shot at understanding and getting the care that they need. I think there's often time to think about family members, think about community supports, think about adjusting medications, think about talking together with the oncologist. I say 97.5% of the time, people end up voting with their feet and, getting more care than they might have initially said, because people just don't say, hey, I want to die on the street from this really painful cancer. No one says that. They say, I'm scared. I've had bad experiences. I don't know if I can trust you. Those are really different things.
Right. I think the other question, I'm looking to see if we have questions from participants, but the other question is just, you alluded to early on about interdisciplinary or education, and thinking about, creative ways that's worked for you, and how you bring people together. Is that formal? Is that tend to be more sort of experiential, through learning through someone's experience with their illness and all the providers? Or do you actually formally bring groups of multidisciplinary providers together around this topic? And are there opportunities for our clinicians in our region to learn, to benefit from some of those?
We more formally have our coalition, our Cancer and Mental Health Collaborative, the Engage Initiative, and we'll be live streaming our symposium this year in April, and it's free. All are welcome. I encourage you to come. There is a network of people. There's more than 600 people who are part of this coalition, who have kind of shared values and really want to be helpful. I think depending on where you are, it's always really important to identify champions, people who can have your back. And depending on where you work, there's probably one doctor who kind of gets a little more than the other ones, or one nurse practitioner. And so that's often a place to start. I think, although it can seem like a lot of time, especially when you're new, it's really important to attend team meetings, to be present. You can't really underestimate how important it is to be present, because then you're there when things come up and you're helpful. And the probably number one reason, in addition to the huge unmet need and the fact that we can proactively identify people through the health record, the reason our trials accrue so fast is because people think we're helpful and they need help. So fundamentally, I think the more situations you guys can be in together to help people together, that really helps.
Great. Those are great words of wisdom. So I wanted to shift gears now. We can certainly continue to take some questions from folks, but wanted to thank everyone for attending today. And we did want to dedicate some time at the end for you to complete a brief evaluation of the webinar that's for our funder, SAMHSA. And our staff has just entered the link for the, should just take a couple of minutes. It's in the chat box, because this is, the link to the evaluations in the chat box, and it is very short, and it's just necessary for us to continue to offer programs like this. And speaking of programs like this, wanted to remind everyone that we do have additional training opportunities on the topic of improving care, medical care for people with serious mental illness. We have a freely available online course related to population management of diabetes that you can access on our website. And as I've mentioned, Dr. Irwin's, this webinar today is really just one of a series of webinars that we're developing on the topic throughout over the course of the next 12 months. So we'll give people a couple of minutes to complete the evaluation and ask any additional questions. Also wanted to remind you how you can sign up for our newsletter, any upcoming you can learn about from our website, learn about our upcoming trainings, online trainings, complete our needs assessment, just learn about resources and research updates, not only from our Region 10 Northwest Center, but from the national network of centers. A lot of expertise in the country. So, please get on our website and explore kind of what the MHTTC network is doing. And we'd love to hear from you all. we'll give people a couple of more questions at a time for the evaluation. A couple more questions. I think I was also struck, Kelly, about your diagram of the continuum of care, and just really thinking about, as someone working in community mental health, about how critical we could be, and really upstream from where you're working, about prevention, screening and prevention and early detection. And would love to hear more about ways you've been creative about no appointment for mammography, and the lung cancer screening. I mean, that would just be amazing if we could do that in our centers. And I feel like I'm based at our county hospital, and we should we should be able to do that. I mean, it's typical community mental health centers, but just wondering how even the mammography, how you were able to pull that off, and what that's been like.
Yeah, no, absolutely. I think something everyone can do is dispel myths about the use of varenicline for tobacco cessation for people with serious mental illness. So in terms of the number one thing we can all do as mental health clinicians is to help people stop smoking, and to know that people with serious mental illness, as long as their illness is well controlled, are no more likely to have side effects from varenicline or Chantix as they are from placebo. But they are 5 times more likely to quit smoking. So that is a huge human rights issue. It's a myth. We can do something about it. And most primary care doctors agree that mental health clinicians, they're comfortable with us addressing tobacco cessation. The truth is we all need to address tobacco cessation. The other truth is you don't actually have to be motivated to quit for Chantix to be helpful or varenicline to be helpful. You don't even have to know. You can just start it and then have, oh, hey, I saved $5 this month. That was cool. There are other motivations. It doesn't have to be all or none, and that's actually more time effective. In terms of mammography, it's another example, I think, of partnership and common sense thinking, of recognizing that there are people that are actually pretty hard to track down. They may not spend all their time in one place. And when we do find them, maybe we should really take advantage of that opportunity to bring them on in for mammography. And mammograms, why would you need an appointment for that? You don't need a needle, and so there was really a motivation also from our radiology department, who's actually increasingly motivated to engage in health equity and reach out to the community, but just also a recognition that why not pilot this? So we piloted it in our population, our homeless population, collaborating with Healthcare for the Homeless, and then we also advocated to extend that to people with serious mental illness. And it's been very successful. And just very much frontline program managers or community NPs can just call me and be like, hey, this person is ready to come in. And I'm like, great, we'll call the clinic, we open them right up, and they come in. And they have a workflow to try to get that done in a day. Other places will use mobile mammography, where the van goes to the person, depending on where you are and how far away you are. I think the different approaches might make sense, but the idea is kind of trying to be common sense and creative about it. There's a lot of these restrictions which are designed or just because of how our healthcare system happens to evolve, they don't actually make sense.
Just reducing barriers, sirens outside here, reducing barriers to access. No, I think that's great. I mean, just thinking about open access to all kinds of care. Great. We want to thank you again. It's terrific work that you're doing. Wish you good luck with. So what's the status of the clinical trial? Are you you're in the process of recruiting?
We are open. You can check out clinicaltrials.gov. We started enrolling in May. And we are a third of the way there almost, actually. So we've enrolled 40 patients and 30 caregivers. So it's rapidly accruing, which is good news.
Right.
So a lot of need.
Right. Well, and thank you for the segue, the teaser about the varenicline, because we're actually one of our activities is going to focus on increasing the use of varenicline. So, kind of stay tuned. We'll just tell our audience to sort of stay tuned for that, as we're really, want to disseminate the new guidelines from the American College of Cardiology, and just really thinking about approaching, much more kind of see a smoker, treat a smoker kind of approach to smoking cessation, which is probably, as you said, the most important thing we can do in terms of reducing cancer risk among our the people we work with.
I think so. Yeah. No, thank you. I'm glad it was a good teaser.
Great.
All right.
Well, thank you so much. Well, thank everyone for joining, and thank Dr. Irwin again for a fabulous presentation. And we'll see you next time.